هنبدأ. هتكلم في البداية عن الصدمة اللي هي الشوك. هتكلم بالإنجليزي في الشرح، وإذا في أحد ما فهم حاجة ممكن يوقفني أو يطلبني يعني أتكلم بالعربي، أو إنه هتكلم يعني بالاثنين. أحاول بس أوصل الفكرة. ففي البداية بس أبغى أشرح إيش هي الشوك. shock it's an insufficiency in the blood supply to the tissue, and the blood usually has the oxygen and oxygen carrying capacity, which is the hemoglobin. So when there is no oxygen going to the tissue and cells, the cells will be deprived from oxygen, and they cannot do the metabolic process which happens in the cytoplasm. So the tissue and the cells will shift from consuming oxygen to do the glycolysis to the anaerobic respiration. Due to this shifting to the anaerobic respiration, lactic acid will accumulate and form inside the cells. Then it will go to the bloodstream. فيعني كل ما في الموضوع إنه الخلايا والأنسجة تنحرم من الأكسجين بسبب نقص الدم. نقص الدم له عدة أسباب. الصدمة عندنا صدمات كثيرة الآن هتحدث عليها. فاللي يصير إن التشو ما يجيها الأكسجين، فتبدأ تستخدم الانيروبيك ريسبيريشن اللي هو التنفس اللا خلوي، إنها ما تستخدم الأكسجين، تحاول إنها تدخر الأكسجين، وخلال الاستخدام هذا حتفرز كثير من lactic acid. Lactic acid will accumulate in the blood, and lactic acid, as you know, it's acid, so its pH is low, and this will cause acidosis. We call it metabolic acidosis in the body. If we have metabolic acidosis in the body, what will happen? Most of the enzymes, most of the protein, most of the ion pumps will not function. The body will try to react and will try to solve this issue initially by doing what we call it hyperventilation. The patient will hyperventilate because stimulus coming from the respiratory center in the brain, trying to wash out the PCO2. So initially we will have respiratory alkalosis, trying to compensate the metabolic acidosis. If we do not give the patient oxygen and fluid to reverse the shock in the early stage, what will happen? The patient will have metabolic acidosis and will go from compensated shock to decompensated shock. And if still the patient does not get the oxygen and the fluid, he will go to the irreversible shock. What does it mean, irreversible? It means we cannot reverse it back. If you burn $100, you cannot return it back. It's destroyed, it's damaged. And the body will start to have hypercoagulable state. We call it DIC, disseminated intravascular coagulopathy. This will lead to end organ damage, and like ARDS in the lung, kidney shutdowns, the liver failure. With all those processes, now we're having multi-organ failure. With the multi-organ failure, the body cannot decompensate. فهي القضية وما فيها إنه عندنا نقص في السوائل بسبب نزيف صار، أو بسبب إنه المريض صار له إصابة، نزيف داخلي أو نزيف خارجي، أو مثلا المريض عنده مشكلة في ما بياخذ محاليل، dehydrated. Patient is having vomiting or diarrhea and he's not able to drink water. That's why he gets dehydrated, and the tissue does not get the fluid, the body fluid and the oxygen, and we start all the process. The type of shock, we have classification of shock. We have four different types of shock. We have the hypovolemic shock. Hypovolemic shock happens due to loss of blood or inability to drink. Loss of blood can happen from any orifices in the body. Let's say if the patient has if the patient is alcoholic, drinking lots of alcohol, and he has varices in the esophagus and liver cirrhosis, and he starts to bleed. Sometimes the patient does not vomit blood, but he's bleeding inside. He will come in early stage of shock, then he will go to from compensated, then decompensated, then irreversible shock because of the bleeding, upper GI bleeding. Sometimes the patient will bleed. Sometimes you will not see the bleeding, but you will see the heart rate goes up and the blood pressure initially goes up, then goes down. Sometimes the patient will bleed from the lower GI. The first example I gave you is the upper GI bleeding, but sometimes the patient comes with lower GI bleeding. Let's say a patient who has colonic cancer or angiodysplasia. With the rectal bleeding, he will lose lots of blood and he will go in shock. This is another type of hypovolemic shock due to blood loss. If, let's say, it's a of hemorrhage, she bled a lot, she will go to shock. Other example of hypovolemic shock. Can anybody give me the most common cause of shock in our ER in Saudi Arabia? What do you think? ايش تتوقعوا؟ معظم انواع I would say no. Okay, I will list the type of shock. We said hypovolemic. The other type, it's cardiogenic. We have also anaphylactic, which is, we call it distributive shock. Inside the distributive, we can say septic shock, anaphylactic shock, neurogenic shock, spinal shock. And the fourth type is distributive shock, which is like there is obstruction of the blood. Either the obstruction due to a lung, like in case of pneumothorax, or due to the heart, like myocardiopathy or extensive MI, especially when the MI affects the LV, the left ventricle. Actually, can anybody guess what's the most common type of shock?
Maybe hypovolemic.
Hypovolemic, okay. I agree with you. Due to what? Due to upper GI bleeding, lower GI bleeding, due to dehydration. Maybe he's an elderly patient and his family left him home and they went to enjoy في الهدا or whatever place and they didn't feed him for 2 days. And now he came altered. He cannot even recognize his sons and daughters. Maybe he's a child who has gastroenteritis and has been vomiting and having diarrhea for the last 7 days. But actually, I think this is the most common cause of mortality in Saudi Arabia. It's the most common cause which is killing us. 17 persons die of this every day in Saudi Arabia. 17 وفية. إيش ممكن يكون شيء بسبب الكحول؟ sepsis. It's trauma. Hypovolemic shock usually happens due to trauma. Motor vehicle accident, this is the most common cause. Sometimes pedestrian، أحد كان ماشي وجاء أحد صدمه، خصوصا في الحج. لو تشتغل في أي مستشفيات الحج حتشوف البيدسترين انجري، لأنهم كمان يطلعوا فوق، ولما مع الترافيك إذا أحد كبس فرمل وهو يكون ماسك فوق تلاقي، أنا شفت أكثر من كيس كانت مستشفى النور يجوا يصير لهم تروما بسبب ذا الشيء، مع انهم مانعين بس بعضهم يخالف، بعض اصحاب التكاسل الله يهديهم يخالف ويركب ناس فوق. فالتروما is very common and the patient usually bleed in the abdomen or in the chest or external bleeding. This is the most common type of shock actually we're seeing in the ER. I would say hypovolemic shock with all the causes of the hypovolemic shock could be trauma, upper GI, lower GI, internal bleeding. I would say also the septic shock is also common. Let me see. In hypovolemic shock, what do you do? What's the management? Management is to give the patient fluid. But before the management, usually in emergency medicine, it's not like you take history, take physical exam, present, then your superior will let you know that we need to do these labs. You wait the labs, see the labs, do the interpretation, go to the patient, talk to them. No. Honestly speaking, the practice in emergency medicine, I go inside the room, I start giving order, the nurse start putting 2 IV cannula, I start doing the examination with my stethoscope. At the same time, I take history, I examine, and they draw blood for lab, so it's like junk, mixed. this is what happened in the ER. لكن بعد ما تخلص تشوف المريض كل شيء انت ترتب نفسك، تكتب الهيستوري، بعدين الفيزيكال بريف، اتس فيري بريف هيستوري، بريف فيزيكال اكزام، وتطلب اللابس وتسوي اكزامينيشن للبيشنت. الهايبوفوليميك شوك انا بس كنت مركز على موضوع التروما لانه التروما مره كومن عندنا في السعوديه. I want to just show you video here. In early stage of shock, you will not know that the patient is having shock unless you pay attention to the heart rate and you predict what's going from the type of injury. Otherwise, if you tell me you're going to recognize shock by having patient with low blood pressure, I will tell you are unsafe physician, because you are leaving the patient to go to stage 3 before you pick the diagnosis and start treating the patient. So we have to act very quickly. In trauma nowadays, does anybody know what does fast mean or e-fast? عارفين الفاست exam؟ اللي هو الالتراساوند focus sonography for trauma. هذه أشعة صوتية نسويها في الطوارئ، نسويها للمرضى الإصابات، نحاول عن طريقها إنه نشوف إذا في نزيف داخلي أو لا، ونحاول نعرف فين النزيف. إذا كان في القلب ممكن نتدخل بإبرة نحاول نسحب الدم، إذا ما كان في القلب كان في البطن على طول المريض حنرسله على غرفة العمليات يسووا له عملية استكشاف ويوقفوا النزيف، يعطوا له دم ويعطوا له أشياء هذه زي كذا. اتكلمت أنا عن الهايبوفوليميك شوك. Second, so far so good شباب.
Yeah.
طيب let me see. احنا عندنا شات وفي ناس just about to say septic shock is also common. I'm sorry for this. Sign of irreversible. في سؤال we have questions here. طيب good. I would just move real quick to the other type of shock. To finish them, then we can discuss the questions. فإحنا قلنا hypovolemic shock, septic shock, distributive shock, cardiogenic shock. Inside the distributive, we can say that anaphylactic shock, neurogenic, or spinal shock. Well, we talked about the signs of shock. Usually the patient will be altered. It's in late stage, in stage 3. We have stage 1, 2, 3, 4. Some of them, they just call it reversible, compensated, decompensated, irreversible. So some of them, they make it just three types, but that's fine. The most important thing is to diagnose the patient, to figure out that he is having shock in early stage. I don't want somebody to come and say, well, I have a patient, his systolic blood pressure is 85 and the systolic is 40. He's not responsive, he doesn't talk to me. When I asked his brother, he said that he was in a car and he had a motor vehicle accident. He was ejected from the car, 100 yards, the AMS came and they tried to intubate the patient. I will be like, seriously, let's go. He's dying. This is stage 3, خلاص. إنه that's why even fluid, we give it in the ambulance. The AMS people, they are trained. They are trained to manage shock, to start fluid. I don't know if they give blood or not, but the most important thing in shock, to compensate, to give the patient fluid, especially for hypovolemic and septic shock. But in cardiogenic shock, it's the opposite. If you give lots of fluid, you might make the situation worsen because the patient will be volume overloaded. طيب, let me see. We talked about the ABG, about the pH. It will go down because the patient is having metabolic acidosis. And we talked about metabolic acidosis. We said, what's the dangerous of metabolic acidosis? It will cause shutdown to all the process in the body. يعني تخيل أنت قاعد في منشأة، فجأة في المنشأة درجة الحرارة صارت 120. Everything will stop. Proton pump will stop. Sodium potassium ATPA pump will stop. Glycolysis will stop. Exchange of electrolytes, everything will stop. وهذا حيسبب, it will cause more damage to the cell. Cell damage will release the contents inside the cell. As you know that usually in the cell, Potassium is very high inside and sodium is high outside. If you have damage in the cell, the sodium will go inside along with the fluid. Usually when sodium goes inside, water goes with the sodium, and the potassium will go outside. So, and this will go to the blood, and this might cause cardiac arrhythmia. So everything will shut down, and the digestive enzymes in the lysosomal vesicles inside the cells will be released. So the cells will be eating itself. This is in irreversible stage of shock, in the last stage. What's our priority when we treat patient with shock? In emergency medicine, we usually say A, B, C. A for airway, B for breathing, and C for circulation. So if you have a patient came to you and he's having shock, let's say septic shock, you might think first that I need to give this patient antibiotic. It's okay. This is one of the most important treatment for this patient. But at the beginning, we have to reverse the process. We have to see the airway. Is the patient talking to us? Is he alert? Because what happens in, especially like in septic shock, or in any type of shock, if you go to stage 3, due to decreased blood supply to the brain, the patient will not talk to you. He will be altered. We call it AMS, altered mental status. So the patient will not give you history. The patient will not know anything. Even the patient cannot protect his airway. Let's say, for example, if he vomited, he might aspirate this. The gastric content might go inside the lung and cause infection, pneumonia. So the patient might start with hypovolemic shock and end up with hypovolemic shock and septic shock. You treat the hypovolemic shock, but now we have aspiration pneumonia in the patient, and you have to treat both. So we said ABC. A, the airway. Is the airway protected or not? If it's not protected, you have to intubate the patient. You have to put the tube inside his trachea and inside his lung. Then you have to ventilate the patient. You have to give the patient oxygen along with the air, with the ventilation. This is in the A. In the B, it's the breathing. If the patient does not breathe, because sometimes when the patient goes to shock, if he stays, let's say, at home for 3 days, he's not eating, he's not doing any normal activity, by the time he comes to the hospital, he will be almost exhausted. Some of those patients, they cannot breathe. And this will cause respiratory acidosis, because PCO2 will accumulate inside the lung. So when you put the tube inside his trachea, and when you start to ventilate the patient and give him 100% oxygen, actually you're giving him oxygen, and you're taking out the PCO2, which is the source of the acid, the acidosis. And you're ventilating the patient, and the oxygen will go to the brain. The patient, maybe after a few days, he will recover, and the oxygen will go to all other organs inside his body. A, we talked about it. B, we talked about it. Then C, which is the circulation, or the volume. Patient in trauma will have hypovolemic shock due to bleeding. If the bleeding is external, what should we do with this? Usually, the most effective
Just
way.
the wound.
What's it? Just direct pressure. This is how we treat any external bleeding. Just put direct pressure on it. Sometimes even direct pressure would be difficult. Like I remember I had a patient and she was bleeding a lot. She was bleeding like hell. And I didn't know where is the bleeding, because her hair was almost full of blood. And I was looking with my light. I spent like maybe 10 minutes just trying to see where is the bleeding. And then another resident came and she took the ACE bandage. عارفة الشاشة اللي فيه له زي المطاطة اللي يربطوا فيه الركبة. And she wrapped it on the head. She did maybe three ACE bandage, and the bleeding stopped, because it was very difficult to stop the bleeding. Sometimes if you have bleeding, like a patient with peritonsal abscess, if you try to drain it and he starts to bleed inside, that's very difficult to stop it. So if the bleeding is very clear, you can stop it by direct pressure. If it's not clear, let's say take history. Maybe the patient is having rectal bleeding, do the rectal examination, PR, check the mouth. If she's a female, do a vaginal exam. She might be having like abortion, or she might be bleeding. So we said the A, B, and C. This is how we manage usually most of the critical cases in the emergency room. Septic shock. I would talk about septic shock. What's going on with the septic shock? With the septic shock, usually due to gram-negative bacteria, has endotoxic toxin, which it's usually in the gram-negative. It's affecting the endothelial cells of the blood vessels and cause damage to this. The endothelial cells in the blood vessels will be like this. But with this toxin, which is a polysaccharide from the gram-negative bacteria, it will open. So all the fluid will be leaking out of the system, out of the arterioles and the artery. So this is kind of distributive shock. What's the treatment for this? We will start exactly like the previous case, A, B, C. After you give the fluid, after you intubate the patient, if the patient needs intubation, if he's altered mentally, he's a candidate for tube. So after you do the airway and the breathing and the circulation, give the patient lots of fluid, then you give the patient broad spectrum antibiotic. You take more history, maybe after a few days you change the antibiotic to narrow spectrum antibiotic. But initially we start usually with broad spectrum. طيب. Septic shock. When you have a patient with septic shock, you have to take history from the patient, trying to expect why this patient is having septic shock. Let's say if he's elderly, he's bedridden, he might be having bed sores. So if you just roll the patient to the right or left, you might see the source of the infection. He might be bedridden and has a Foley's catheter which hasn't been changed for the last 6 weeks or 4 weeks. So he might be having the UTI, urinary tract infection. If the patient has renal stone, maybe he developed pyelonephritis. Maybe the patient is, let's say he's a kid and he has been vomiting, he has gastroenteritis. Maybe he's a patient who developed pneumonia and has been treated with antibiotic unsuccessfully for the last 2 weeks. Now he developed septic shock due to the infection in the lung, the pneumonia. And sometimes the patient will be altered, not due to the shock, but it's due to CNS infection like meningitis or encephalitis. So you have to be careful about this. And in septic shock, usually in shock, we said heart rate will be high initially. Blood pressure initially goes up, but in the third stage, it goes down. Temperature, in septic shock, temperature will be high or low? What do you think? It should be high because there's
low amount of blood.
Okay. Yeah, most of the time it's high because we have organism. We have invader went inside the bloodstream and the body detected this and increased the temperature to make it hostile environment for this organism, to evacuate the organism or trying to fight the organism. But sometimes in late stage of shock, the organism will go to the thermoregulator in the brain and will cause damage to the thermoregulator center. And if you have a patient of septic shock and his temperature is 35 or 36, it means this is very poor prognosis. It means the organism was severe enough to start affect the brain and damage the thermoregulator centers. But do not exclude shock, septic shock, based on temperature, because temperature is normal. And this happens in elderly. Elderly usually, I wouldn't say usually, but sometimes elderly people, they do not develop the classical sign and symptoms of the pathology, or what they call it bookish finding. It's not like what's in the book. If the patient has right lower quadrant pain, started periumbilical area, then migrated down, patient start to have nausea, vomiting, white count high, temperature is mildly high, this is appendicitis. In elderly, sometimes it doesn't happen like this. It happens like nothing. He does not eat for 3 days. And you come examine him, he does not have the McBurney sign. He doesn't jump or something, because sometimes the peritoneum has degeneration with the age. That's why you have to be very careful with the elderly. those people, they do not present in classical presentation. Sometimes they present with the opposite. So we talked about the septic shock. We said initially you start broad spectrum antibiotic, then you move to narrow, and try from taking history from the patient to figure out what's the source of the organism and try to target your antibiotic based on this source. I would move to the cardiogenic shock. If anybody has any question, you can go ahead and ask. Anybody has comment, you can just chat, voice, hi, up, speak Arabic, English, German.
طيب
No, I think it's fine until now.
هو عندك سؤال؟
أيوة عندي سؤال.
تفضلي.
إذا سمحت دكتور، الحين جايني بيشنت عنده هايبوفوليميك شوك، لنفترض مثلا جي اي بليدنج. الفلويد أبغى أعرف كم نعطيه فلويد، وهل نعطيه بلاد في الاي ار، نقدر نعطيه بلاد في الاي ار، وفور هاو لونج، والكوانتيتي كم نعطيه؟
We usually calculate the dose. Let's call it dose, although it's not medication. I would say give 20 cc per kg. So if he's 70 kilogram, let's give 1 liter, 2 liter, 3 liter. You can go up to 6 liter. If you reach to the 6 liter and then the patient still is not responding, it means you need to start giving. Of course, you will give blood. You will give FFB or platelets. But you need to start pressure as well. In the pediatric, it's 20 to 40 ml per kilogram.
طيب التايم على كم نعطيه؟ يعني نفترض إنه الوزن 70 على في 20 يعني 1400 سي سي. طب على كم نعطيه الوقت؟
لتر ونص يعني.
في الساعة؟
لا مو في الساعة. اللي حيسوي لك هي في الساعة النيرسز. I'm sure they will do this. خلاص؟ طبعا أنا ما أتهم النيرسز لكن this is what happens. Usually you tell the nurses, okay, give let's say 2 bags of normal saline or Ringer lactate.
Yes.
Give it bolus. When you say bolus, it means as fast as possible. Technically speaking, bolus is 10 minutes, over 10 minutes or 5 minutes. It means you go with 2 wide gauge cannula, 18, let's say 18 or 16 even, in both antecubital fossa, and you give the 1 bag, you finish it in 10 minutes. Even if you need to squeeze it, you need to do whatever to give it real quick, do it. But honestly speaking, what happens in the hospital, usually they give it over like, let's say 20 minutes, sometimes even over 30 minutes, sometimes for an hour. I just leave and I come after 45 minutes and still it's hanging there and dribbling. So you need to just emphasize that, give it as soon as possible. Just say bolus. Bolus means give it as soon as possible. And I think the fastest thing is that 10 minutes, let's say 7 to 10 minutes.
What about the type of fluid?
You can give, we usually give normal saline in the ER. Surgeon, they like Ringer lactate. Normal saline has sodium and chloride. If you give lots of it, let's say 3-4 liters, you will worsen the acidosis. So it's preferred to shift to Ringer lactate after like 1 liter or 2 liter. Nobody will say you're mistaken. If you give normal saline, that's fine. If you give Ringer lactate, that's fine. I usually give normal saline because I'm ER doctor. But when I work with the surgeon, they ask Ringer lactate. I would be fine. Okay, Ringer lactate, that's fine. Give Ringer lactate, give normal saline, give as long as you give it fast, that's fine. And the same dose, it's 20 cc per kilogram.
طيب دكتور، السؤال الأخير، متى نقدر نوقف السوائل نقول البيشنت إنه كومبلاين وصار كويس وفيتالي ستيبل؟
حلو. Good question. Based on vital signs?
Yeah.
And based on the patient mental status, patient situation. Sometimes the patient will be altered. He doesn't know anybody, he's not speaking to you, stuff like that. Usually the patient with shock usually will get admitted to the hospital because they go to shock because they have like major illness. But sometimes, like I treated one patient in one of the hospital in Jeddah. I think the patient, he didn't eat for like 3 days. I don't know why. Maybe he developed infection or something. Then he started to wandering. He doesn't know. He just mumble. He stumble. He fell down. He doesn't know his sons. When he came to the hospital, we gave him just like 2 liters of normal saline, or 2.5, which is like almost 5 bags of normal saline. After 1 hour or 2 hours, the patient was completely fine and normal, and he started to recognize his sons and those people. This patient can be discharged, yeah. He has normal vital signs. Altered mental status he does not have any more altered mental status, and we checked everything head to toe, like we did chest X-ray, we sent urine for urine analysis, we did other physical exam, and we even sometimes send blood culture. Everything was fine. Yeah, we can discharge the patient home.
Okay, what about blood? When can we give patient blood? For example, hemoglobin 10, 7, 8, according to medical cases. For example, patient with hypertension or heart failure, how much blood we give him and when?
Okay. You mean patient with heart failure and he has hypovolemic shock?
أيوة.
Yeah, that's kind of complicated, because this patient is depleted. He doesn't have lots of fluid because he's dehydrated. At the same time, he's overloaded because he has heart failure. What happens in heart failure? All the blood goes to the periphery, to the legs, to the sacrum. Why? To reduce the load in the heart. So if you give him fluid, the fluid will accumulate and will exacerbate the situation. I would say treat him like other patient, give fluid but with cautious. Most likely those patients will need central line, and through the central line you can monitor how much fluid you give to this patient, especially if he's cardiac patient. Regarding the blood, most of the textbook, they mention the magic figure, which is 7. They said usually the patient has hemoglobin 7 and he's symptomatic, give blood. I do not advise going through this number. Why? Because you will see a lot of sickle cell patients and they have 6 and 7 and they do fine. They're perfect. You cannot give those patient blood based on this number. Sometimes you have patient with the 7 and he's not symptomatic. Why should I give him blood? Is it because the figure, the number 7? And sometimes the opposite. You have patient with 9 but he's symptomatic and he's pale and he lost many blood. So I would say 7, but be cautious with this number. Go with the clinical signs. If the patient needs, give him. If the patient lost, if the patient does not recover with the fluid, with like after 4 liters or 6, you can start giving blood or giving FFB or platelets. Yeah, just for cardiac patient, just be careful. You do not want to overload the patient, then the heart will go to acute heart failure. And usually monitor the patient. You can give dopamine or dobutamine, especially for a heart failure patient, to increase the contractility in the heart. And the central line should be inserted in the patient to monitor the CVP, which is the central venous pressure.
Yeah, thank you,
but
doctor.
It's complicated. It's not easy. It's not easy. It's an easy question and easy answer, but in real life it's complicated. I remember I had one patient. That patient has heart failure, and his EF, the ejection fraction, was almost like 15. His heart is so weak. Maybe the contraction in the heart is like this. It's 15, the ejection fraction. Normally it should be more than 60. And the patient said, came to the room, I give him fluid, give him 1 bag of normal saline, then another one. Then I was like, he's volume overloaded. His legs were edematous, and I listened to crackles in his chest. JVD was distended up to the ear. I was really confused what to do with this patient. And I even called the previous shift. He was a consultant in the ER. I was like, what should I do with this patient? He said, this is a very complicated patient. You need to start dobutamine or dopamine, and you need to insert central line. Well, I don't know how to insert central line back then, and I've never given the dopamine or dopamine. Then he was like, talk to the specialist, and let the specialist to the ICU. This patient is not easy. Don't mess with those patients, complicated patient, because his main problem is in the pump. Heart is not pumping well, and now he's dehydrated in addition to that. If you give lots of fluid, he will go to heart failure. If you do not give fluid, he will go to shock, hypovolemic shock. So cardiogenic shock is difficult. And it's my next topic, the cardiogenic shock. Do you have any question, or we just move?
To me, no, thank you.
الجميع أي أحد عنده سؤال, you can just, you can stop me and raise your hand, يلا, or do whatever. Cardiogenic shock is our next. It's due to low cardiac output. Low cardiac output, most likely due to damage happens inside the heart. What do you think damage inside the heart, like what? Causes of cardiogenic shock might be myocardial infarction, especially if the infarction happens. Say that again.
Ischemic diseases.
Ischemic disease. Yeah, ischemic is actually chronic issue, but sometimes, ischemic disease will cause myocardial infarction. If the myocardial infarction is extensive, like 40% of the left ventricle was damaged due to the MI, the heart will not pump the blood very well. It will be very weak. So stroke volume wouldn't be the normal stroke volume usually that heart is pumping. So cardiac output will decrease. And this is a problem because stroke volume and heart rate, this is what equal to. Do you mind if I share screen with you guys?
Yeah, تفضل دكتور.
Right. I'll just clarify in this point. Hold on a second. ابغى بس اشرح هنا
تمام وضحت الحين. طيب تقديم الجميع
واضحة ولا فيها مشكلة؟
اي واضحة دكتور تفضل.
طيب let's say cardiac output يساوي stroke volume multiply by the heart rate. If this goes down, stroke volume goes down, this has to go up to compensate. Otherwise, your cardiac output will be jeopardized. The problem that in myocardial infarction, what happened? You have damage to the heart muscle. And let's say this is the heart. This is the LV. So here is the LV, and you have extensive damage to the heart, more than 40%. Now your stroke volume will decrease. Why? Because this muscle is not pumping very well. So this goes down. So the heart will increase the heart rate to compensate for this. When the heart rate increases, the consumption of oxygen will increase. And this will cause another problem now, because the increase of oxygen consumption, it means the heart needs more blood. More blood needs to be pumped by the heart through the coronary artery to supply the heart, the left ventricle, right ventricle, and right atrium. So it's like vicious circle. Let me get this back. رجعت الشاشة. فهي هنا مشكلة الكارديوجينيك shock, especially if it's myocardial infarction. This is a problem. You have problem in the heart, and now the heart is not pumping very well, and due to the heart is not pumping blood very well, the heart itself is getting ischemia. Other causes of cardiogenic shock could be cardiomyopathy or myocarditis, which is viral Coxsackie virus affect the heart. And usually how you know the patient in cardiogenic shock, you examine the patient, you take the vital signs. Sometimes the heart sounds will be muffled because the heart is is surrounded by fluid. If it's left ventricle infarction, fluid will accumulate inside the lung and the patient will start to have pulmonary edema. Sign and symptoms of pulmonary edema, the patient will be having shortness of breath. If it's the right side of the heart, the JB will be increased. You do the normal labs. Sometimes you see ST elevation in the EKG, so it means the patient is infarcting right now. If you see the low voltage in the EKG, it means the heart the heart may be surrounded by fluid, so we might have cardiac tamponade. Cardiac enzyme, if it's elevated, troponin is very high, it means this gives you a clue that the patient is having infarction. And we will treat the cause. So if the patient has MI, we have to give heparin. Sometimes we send the patient, we will give oxygen, aspirin, and nitrates to decrease the preload. Patient need to go to the cath. If you do not have cath lab in the hospital, you can give thrombolytic to the patient. This is the cardiogenic shock. Did we spend 30 minutes on the topic? إبراهيم عدينا 30.
عدينا ايوه، بس كم باقي كده دكتور؟
ما باقي شيء خلاص. ما باقي بس 2 topics real short. I'll make them in like 3 minutes.
No problem, doctor. Take your time.
Last, distributive. I would say we have distributive and obstructive. Distributive, we have problem in the blood vessels. We said the septic, we can consider it type of distributive, but the most common type of distributive shock, like anaphylactic shock. Patient eats, let's say, shellfish or eggs or whatever, or nuts, and then he starts to have extreme vasodilatation in the blood vessels, and all the fluid will start to be oozing out of the arterioles to the body. This is a very dangerous situation, can kill the patient, anaphylactic shock. If it's due to allergy, it's type 1. If it's due to blood or medication, it's type 3. How you treat it? You give the patient epinephrine, you give the patient steroid, methylprednisolone, you give the patient antihistamine. Sometimes you need to intubate the patient, especially if it was angioedema and the patient has facial swelling. Sometimes they give the patient atropine to increase the heart rate. Then we have the neurogenic or spinal shock. The difference between them, neurogenic is due to loss of the sympathetic tone in the blood vessels. It happens due to trauma or due to injury to the spinal cord. Spinal shock, actually nobody knows exactly how it happens, but it's type of shock that happens probably due to like efflux of potassium out of the cells to the cytoplasm, and it does not involve the circulatory system, while neurogenic shock will involve the circulatory system. So the patient will have bradycardia and he will have hypotension because there is vasodilatation in the vessels. How you treat it? You will give the patient fluids, you give the patient pressors like dopamine, dobutamine, and you can give also atropine. The last topic is the distributive shock. Distributive shock is a shock due to something compressing the heart from outside. Like what? Could be trauma, could be heart contusion, could be, let's say, cardiac tamponade. Maybe the patient had extensive myocardial infarction and now there is a left ventricle rupture, the blood goes surrounding the heart, so the heart now is getting squeezed because there is something pushing. Maybe the patient has trauma and he has now pneumothorax. Pneumothorax is type of distributive shock because the lung, the air will go between the visceral pleura and parietal pleura and start to squeeze the heart. So the heart cannot pump blood. That's all.